they are very well tuned to what is latest in the field. And we have Dr. Parvati, Dr. Hemchand, and we have a nutritionist who has done a lot of work in pediatric in diabetes mellitus, and Dr. Cheryl. So it's going to be a good session for everybody. I hope all of you get put on. Quiz is there after this program, and I hope the PGs will be taking part in the quiz. I will start with uh, to share the slides. You can see the slides.
Yes.
Yes, sir.
Yes.
Yeah.
Yes.
So this, as we said, we're calling it the clinical pearls in childhood diabetes mellitus, and as I said, we call it the pediatric potpourri. It's all available on the YouTube, and this session also will be available for the next many months on YouTube. So PGs can go and look at this. So what our experts are talking about over the next few days and months. So this is what pediatric potpourri is all about. It's organized by the IIP Cochin branch and IIP Kerala State branch. It's a flagship project of the IIP Cochin branch. We'll start off with this with today. As I was going to, as I already said, we're going to learn about advances in diagnosis and management of some aspects of diabetes in children. We start today with Dr. Parvati, who's going to present a few cases while discussing the diagnosis of childhood diabetes. And Dr. Parvati is a young pediatric endocrinologist. She's done a fellowship in pediatric and adult endocrinology from the Indira Gandhi Institute of Child Health under Dr. Bharati at Bangalore. Pediatrics was from, everything was from Government Medical College Trivandrum, MBBS, DCH, and MD. And she's now the consultant pediatrician and pediatric endocrinologist at Aston University, Kochi. Great teacher, she's got a passion for teaching. And I'm sure all of you will enjoy her presentation. Over to you,
for the introduction to the topic. So pediatric diabetes, as we all know, it is definitely increasing, not only in India, but globally, it is definitely emerging. And type 1 diabetes has an exponential increase as per the statistics from the recent International Diabetes Federation Atlas. If you see the statistics from the IDF Atlas 2019, you can see the new cases of type 1 diabetes in the age group 0 to 14 years. In 2019, you can see India is topping the list, even above USA. And on your right-hand side, you can see the list, that is the existing number of type 1 diabetes in the age group 0 to 14. There also India is topping the list. In the previous years, India was behind US. So definitely there is an exponential increase in the incidence of type 1. Recognition of other forms of diabetes are also coming up. So as pediatricians, we might be encountered with diabetic children. Probably earlier we knew that type 1 diabetes was the most common form of diabetes in children. Still it is. When we have a newly diagnosed diabetic child in our OPD, usually the parents, the family, the children are young, they might not be involved in the whole traumatic process. Usually adolescents have a tough time. So a newly diagnosed diabetic child, the family comes to you with a lot of questions. Why our child? Which type of diabetes does my child have? Is it type 1 or type 2? Is it lifelong or is it curable? Does my child need to take insulin lifelong, or can it be cured with oral drugs? Is there any long-term complication? Does it affect my child's growth, puberty, fertility, and career education? So a lot. So that classification of diabetes. So it's very important to identify the type of diabetes. It is not type 1 alone, even though type 1 is the most common cause of diabetes in childhood and adolescence. There are other forms of diabetes which are increased. Diabetes, as we all know, as per ADA, it is to type 1, type 2, other forms of diabetes, and gestation. But for childhood diabetes, I think this could be a good classification which we can remember and use it for in our further case scenarios that are coming up. So it could be type 1 diabetes or type 2 diabetes. Monogenic diabetes. Monogenic diabetes is because of a single gene involvement. Predominantly, it could be due to the genes affected in beta cell functioning. So it could be either two types, that is maturity onset diabetes of the young, or MODY. Around 13 to 14 types of MODY are described so far. And then you have neonatal diabetes, which usually presents in the infancy, more commonly in less than 6 months of age. And monogenic diabetes, the other variety, could be because of insulin receptor defects, especially lipodystrophies, and also it could be a part of other autoimmunities like autoimmune polyendocrinopathy or IPEX syndrome. And the fourth group could be a secondary diabetes. As you might be knowing, there are a lot of children who have or who are on steroids, a nephrotic syndrome child on steroid presenting with hyperglycemia, polyuria, polydipsia, or an acute lymphatic leukemia child who's presenting with features of diabetes because of the steroids as well as the L. asparaginase. So those come under the secondary diabetes. So when would you consider a non-type 1 diabetes? So usually type 1 diabetes is a classical presentation. We all know polyuria, polydipsia, weight loss, and most of them or many of them present with the, if undetected, can present in diabetic ketoacidosis. So when would you consider non-type 1 diabetes? So when would you consider a type 2 diabetes? A type 2 diabetes is usually seen in a peripubertal age group, and usually it could be associated with obesity. The child could be either overweight or obese with features of insulin resistance like acanthosis nigricans, absent autoantibodies associated with type 1, and a high C-peptide, and there could be a strong family history of type 2 diabetes. So it's very important to consider type 2 diabetes in a peripubertal child who has all these features. And on your left-hand side, you can see when to consider monogenic diabetes. Monogenic diabetes, as I said earlier, it could be either neonatal diabetes or MODY. So neonatal diabetes, especially an infant presenting with hyperglycemia or diabetic ketoacidosis, it's very essential to rule out a monogenic diabetes because it has got implications on further management as well as prognostication. So a diabetes in less than 6 months of life with extra pancreatic features. Extra pancreatic features might include an optic atrophy, deafness, all those things could point to a single gene mutation. A mild, stable fasting hyperglycemia, which is usually an insidious in onset. You should be thinking about a monogenic diabetes, and diabetes in more than 2 generations without typical features of type 2 diabetes or type 1 diabetes, all monogenic diabetes, mainly MODY. And secondary diabetes, especially when you have a child with a chronic illness, a nephrotic syndrome, or acute lymphatic leukemia, or child with thalassemia, sickle cell disease, who presents with polyuria, polydipsia, it could be a secondary diabetes. So with this background, let us case scenarios. I just have 4 case scenarios which are representative of the types of diabetes in children. So this is a very common scenario which none of us would miss. This is a 10-year-old girl who was previously normal. She presented to the pediatric emergency department with complaints. The child had altered sensorium, vomiting, and hurried breathing, 1 day duration. She was referred from a peripheral hospital and IV fluids. On examination, the child was drowsy with a deep sighing respiration and dehydration. So an intelligent resident went to the mother and took a detailed history. So the mother gave a history of polyuria and polydipsia, which was present for last 2 days prior to the onset of the altered sensorium and hurried breathing. They went to a nearby hospital and took an ultrasound abdomen, which was okay. So getting this history, the resident went and checked the blood sugar. The blood sugar was definitely high, and the urine ketones was checked, which was large. And the blood sugar, the corresponding plasma blood sugar was 550. So previous slide. Yeah. So with this high blood sugar and ketone positivity, venous blood gas was ordered. The pH was 6.9, the bicarbonate was 5, the anion gap was very high with a ketone positivity in the urine. So, and meanwhile, so this acute presentation, as we all know, is a diabetic ketoacidosis. So what is the biochemical criteria to define diabetic ketoacidosis? So diabetic ketoacidosis, all the symptoms, all the polyuria, polydipsia, and weight loss with the corresponding blood sugar more than 200, with a serum ketone positivity or a urine ketone moderate to large, with the presence of acidosis. Acidosis, it could be pH less than 7.3 or a bicarbonate less than 50. So Yeah. So what are the clinical features of type 1 diabetes? It's very easy to diagnose when we have all the telltale evidences of type 1 diabetes, but always it may not be the case. Most often what happens in younger children is that the polyuria, the polydipsia may be overlooked, especially in hot climates. It might be missed. And a recent onset secondary aneurysm, a child who has been dry at night, developing a recent onset aneurysm also needs to be evaluated whether it's an onset of a hyperglycemia. Failure to gain weight or weight loss despite increased appetite, and recurrent candidal vaginitis in a pre-pubertal girl. Always look a check for a blood sugar. We have had children who came with cervical lymphadenitis, a blood sugar check found to have a hyperglycemia. And also, if we are not able to pick it up earlier, these children might land up in diabetic ketoacidosis. So it's very important to detect these symptoms and suspect diabetes before they slip into diabetic ketoacidosis. So this is the well-known model of the natural history of type 1 diabetes put forward by Eisenbach. On the y-axis, you can see the beta cell mass, and on the x-axis, it is the time. So with a genetic predisposition, which is mostly contributed by the HLA, probably HLA-D2 and DR, and with other genetic loci that are involved, you have viral trigger. Many viral triggers have been implicated. There is an initiation of the autoimmune response, and you have circulating autoantibodies presence, and this leads to progressive loss of beta cell. You have an insulitis, which progressively pre-diabetes as well as, and in the final stage, when 80 to 90% of the beta cell mass is lost, you have the clinical presentation of diabetes. So that is the story of a type 1 diabetes, which we are all familiar with, and the most common cause of childhood diabetes. Let us go to the second case. So previous slide. So this is a infant who's presenting with hyperglycemia. So can I have the previous slide? Yeah, so this is a 7-month-old baby who's brought to the pediatric casualty with a history of cough, cold for 2 days, and fast breathing 1 day. The baby was referred as a case of acute bronchiolitis. But the mother was very intelligent. The mother herself came to the medical officer and gave the history that this child has been passing urine excessively for the past 2 weeks. There was no significant weight loss. But the medical officer on examination found that this child was severely dehydrated. So excessive urine output, but always think about a possibility of diabetes. So this child was born out of a consanguineous marriage with
Breaking.
Yeah.
Breaking, Parvati. Your voice is breaking.
Am I audible, sir?
No, you're breaking in between.
Okay.
Now it's okay.
Okay, sir. Okay. So next slide. So on evaluation, the baby's blood sugar was found to be very high, was 779, and urine ketones was large. The pH was 7, and with a bicarbonate of 3. Again, this is a similar picture. This is a severe diabetic ketoacidosis with a HbA1c of 16.6. But this baby's autoantibodies was negative. So this is a classical picture where you would want to rule out a monogenic diabetes, especially in an infant less than 12 months, presenting with diabetic ketoacidosis. It is imperative to rule out a monogenic diabetes, but the initial management definitely will be with insulin. This baby was managed as a severe decay, just as in the first case, as per ISPAD guidelines. The child was started on an insulin infusion rate of 0.05 unit per kg per hour. Child improved, and meanwhile, genetic studies was arranged, and this child came positive for KCNJ11 mutation. So this was diagnosed as a neonatal diabetes. So the advantage or the importance of these children who have KCNJ11 and ABCC8 gene-specific mutations, which are found to cause neonatal diabetes, they respond to oral sulfonylurea. So you can switch over from insulin to oral sulfonylurea. So this baby was shifted to neonatal diabetes usually presents in the first 6 months of life. And usually these children could be SGA or having IUGR. It could be transient or permanent, and half of the cases are transient with or without recurrence. So what are the most common genetic mutations? As I said, KCNJ11, ABCC8, IPF1, or FOXP3 associated with the IPIC syndrome. And out of these, KCNJ11 and ABCC8 mutations are responsive to pharmacological doses of sulfonylurea. So that's why it's very important. The most important test in a suspected neonatal diabetes in an infant with diabetes would definitely be genetic testing after stabilizing the child. Going on to this third case, this is a 12-year-old girl, a peripubertal girl who presents to you with repeated skin infections. She's definitely obese with a BMI of 31, acanthosis nigricans, and fasting blood sugar and postprandial blood sugar was ordered because of the increased risk factor, and FBS was found to be elevated 138 and PPBS was 210. Her HbA1c was elevated. Fasting C-peptide was on the higher side. Her GAT65, the autoantibodies, was negative. So this is a classical case of type 2 diabetes because of the increasing obesity epidemic. We are all seeing more number of type 2 diabetes in our OPD. So these cases, usually if the blood sugar is stable and the HbA1c is roughly less than 9%, they can be managed with metformin and lifestyle modification. So it's very important to diagnose these diabetes rather than putting them on insulin. These children usually respond to metformin in the initial stages. So type 2 diabetes, as we know, it's a polygenic disease. It's very important to consider the possibility of type 2 diabetes in children and adolescents, especially when they present you with overweight, obesity, evidence of insulin resistance like acanthosis nigricans, polycystic ovarian syndrome. Usually in these children, the fasting insulin or C-peptide could be normal or elevated, and most of them have a positive family history of type 2 diabetes, and they have a incidental or atypical presentation. They don't usually have the rapid form of presentation like in type 1, but a very small percentage, maybe 10 to 20%, could present with diabetic ketoacidosis also, and look for other components of metabolic syndrome, which could help you in diagnosing a type 2 diabetes. So the previous slide. Yeah, this is my last case. This is a young boy who was posted in the ENT department for tonsillectomy, and on the in the preoperative evaluation, a fasting blood sugar was done, which was found to be 136. So it is elevated, and his HbA1c was also elevated 6.6%. So we went to the family history. You can see lower down, this is a boy, 8-year-old boy who asymptomatic, and you can see his mother was diagnosed with gestational diabetes at the age of 24 years. She required insulin during pregnancy, and her father was diagnosed to have diabetes, thought to be type 2 diabetes. He was put upon metformin, where 3 generations are involved. They have early onset diabetes. It could be treated as a type 2 diabetes, gestational diabetes, and the children or the adolescents presenting with a mild fasting hyperglycemia. So again here, a monogenic diabetes, MODY was suspected, and the genetic testing confirmed the glucokinase MODY. So this is a classical picture of a maturity onset diabetes of the young. They usually have an autosomal dominant inheritance. Early onset of diabetes before 35 to 40 years, we have 3 generations involved. We have mild hyperglycemia. Usually they'll not be obese, or any other features of insulin resistance would be absent, and the autoantibodies would be negative. And you would find evidence of C-peptide protection in them. Diagnosis of diabetes, which is not seen in a type 1 diabetes. So here also molecular diagnosis is very important to identify the cause, prognosticate, and assess the risk in the family members, and for diabetic education. So in general, how would you differentiate between the types of diabetes? Type 1 diabetes and type 2 diabetes, they're polygenic, and the monogenic diabetes includes neonatal diabetes and MODY. And the age of onset, type 1 diabetes could present from 6 months till any age. Actually, it can present at any age. Type 2 diabetes is usually peripubertal, and monogenic diabetes, MODY, it is usually can occur up to 1 year of age. So the presentation, usually type 1 diabetes is a rapid presentation, as I mentioned, with all the telltale evidences. Type 2 diabetes, it could be a slow presentation. Rarely it can present with ketoacidosis. Monogenic diabetes, usually MODY presents with a mild fasting hyperglycemia. Few of them might not require any medications. Few respond to oral hypoglycemic drugs. And autoimmunity is a key factor in type 1 diabetes. And ketosis is more common in type 1 diabetes, but it could present in type 2 diabetes and neonatal diabetes also. And the insulin secretion, it is absent in type 1, whereas the insulin sensitivity is decreased in type 2. And type 1 diabetes requires lifelong insulin therapy, and type 2 diabetes, usually they have episodic insulin dependence. And obesity, as I mentioned, obesity or overweight and other features of metabolic syndrome are more common with type 2. But we should understand that based on the increase in obesity in the population, and acanthosis and other features of insulin resistance are more common in type 2 diabetes. So the next slide. Yeah. So how to diagnose, what are the diagnostic criteria? HbA1c more than or equal to 6.5%, a fasting blood sugar more than or equal to 120, or a 2-hour plasma glucose more than or equal to 200 milligram per deciliter while you're doing an oral glucose tolerance test using a glucose load, maximum 75 gram, or it is 1.75 grams per kg. Or in a patient who has all the classical symptoms of hyperglycemia, a random blood glucose more than 200. Here it's very important to note that a child, a type 1 diabetic child who's presenting with all the telltale evidences with a random blood sugar or fasting sugar, which is a diagnostic, we needn't put the child to an oral glucose tolerance test, because that probably would increase the hyperglycemia and that child would be slipping diabetic ketoacidosis. So in a type 1 diabetic child or in any diabetic child who has all the classical symptoms with a random blood sugar elevated more than 200, there is no need for a OGTT. So what are the challenges as far as clinicians are considered in diagnosing diabetes? The polyuria, the nocturia, the polydipsia, the weight loss, depending on the severity, could be overlooked. And diabetic ketoacidosis, especially because of the tachypnea and the hyperventilation, it could mimic other respiratory illnesses like bronchiolitis in a young child, asthma or pneumonia in older child. Because of the abnormal sensorium, it could be misdiagnosed as meningitis, encephalitis, septicemia. These children would land up with the pediatric in vomiting, would land up in the pediatric gastro department with suspecting gastroenteritis, sepsis, pancreatitis. They could present you with recurrent vaginal candidiasis, especially in a prepubertal child, balanitis, skin infections. And the important point that we need to remember is that all need not be type 1 diabetes. Please consider the possibility of type 2 diabetes and monogenic diabetes like MODY in children. So next slide. This I've already mentioned. In the classification of diabetes, the issues that could arise, there is a lot of overlap clinically, and also autoantibodies. Usually, there are 4 types of autoantibodies that are commonly checked. That is, the most common is the glutamic acid decarboxylase 65. Then you have the zinc transporter antibody, insulin autoantibody, and insulinoma antigen 2 antibodies which are checked. So they could be positive in 80 to 90% cases, but this positivity is a bit less in Indian type 1 diabetes. And type 2 diabetes, we have mentioned all the classical features. And in monogenic diabetes, it usually has an autosomal dominant pattern with a mild hyperglycemia. Usually they need not be obese. And so monogenic diabetes, they could appear like type 1, but the antibodies would be negative and the C-peptide would be normal beyond 2 to 3 years of diagnosis, which doesn't happen in type 1. So in type 1, there could be overlap in the C-peptide, especially in the first 1 year because of the glucotoxicity or the insulin resistance. The C-peptide level could be elevated. So C-peptide need not be diagnostic in type 1 diabetes, especially in the first year. But beyond 1 to 2 years, if the C-peptide is detectable or above normal, definitely it is unlikely. So next slide. Yeah, so diagnostic challenges, just I'm repeating it. There is a threefold increase in family history of type 2 diabetes in children with type 1 diabetes. That confusion, and also 30% of newly presenting type 1 diabetes could be obese depending on the population frequency of obesity. And ketosis, diabetic ketoacidosis could occur in around 20%, 20 to 25% of children with type 2 diabetes. And as I mentioned now, overlap of C-peptide measurements could occur at the onset and within first year of onset of diabetes. And around 10 to 30% of type 2 diabetes could have autoimmune markers. So it's very important to follow up the child clinically and determine the clinical course to identify what could be the cause. You may not be able to classify. So there is a lot of presentation of lean type 2 diabetes, obese type could complicate your diagnosis. So the take-home points from my presentation in diagnosing diabetes would be type 1 diabetes definitely is the most common form of diabetes in children. Not the previous slide. Not all forms of diabetes need not be type 1, especially when you have the clinical handles suggestive of a monogenic diabetes or type 2 diabetes, it's very important to suspect them because they have got implications in management, prognostication, screening, as well as educating the family. And knowing the type of diabetes definitely influences the management. Strongly consider if suspecting monogenic diabetes. As I said, at the initial phase, if you're not sure which type of diabetes it is, based on the sugar level HbA1c, the child has to be treated with insulin if the HbA1c is high and the sugars are high. And probably the further clinical course will help you to find out. And also other tests, as I mentioned, would help you to find out what is the type of diabetes. And all these families, these diabetic kids, parents and families, they not only require a prescription of insulin and a dietary advice and others, they definitely need a team management. We need a proper team with a pediatrician, pedendos, dietitian, diabetic nurse, and also they need a lot of motivation. The families need motivation. You need to keep on, they need a 24-hour support service for their emergency doubts, especially in the first 1 to 2 months. The first 1 month after diagnosis of type 1 diabetes is a crucial phase. They get a lot of advice from others, and there is a chance that they can stop insulin. They need to be advised about the honeymoon phase. All these advices and counseling need to go with a lot of motivation.
Thank you, Dr. Parvati. That is a fantastic presentation. Lot of take-home points. Medical management of childhood diabetes, type 1 diabetes requires much more than just the knowledge of the subject. In-depth understanding of the child, the adults, and the environment, family, economics, and so much more. And we have a passionate teacher in Dr. Hemchand to enlighten us on the ambulatory care of type 1 diabetes. Dr. Hemchand is a pediatrician who's working at Mehta Hospital in Chennai. He did his PDCC at Pune, Bharati Vidyapeeth, ESP Clinical Fellowship in Birmingham Children's Hospital, and ISPAT Clinical Fellowship in Washington University. He's very well trained. He's a consultant in Endo Kids Clinic, Chennai, South Zone convener of the IEP 2015 Road Charts TOT, 20 peer-reviewed publications in pediatric endocrinology, and is a co-editor of the second IEP textbook of pediatric endocrinology. Numerous presentations, delivered keynote addresses, the diabetic carb app and DKA app for practitioners, innovative teacher award, and organized many pediatric endocrine meetings in Chennai for pediatricians. And his areas of interest are growth charts, growth hormone therapy, type 1 diabetes. He's a great teacher, as I've heard him. Over to you, Hemchand, for your presentation.
Good evening, everybody. So I think over the next 20 minutes, I'll try to be as quick and brief to talk about day-to-day aspects in the care of children with diabetes. I start my presentation with this slide, which shows a typical eating pattern of a child in your house and my house. The child does not have breakfast, doesn't have lunch, doesn't have a snack, has a light dinner. Next slide. And the very next day, the child has everything. Next slide. This is a typical child. And just because the child has diabetes doesn't mean the child is going to eat different. Remember, type 1 children are also normal children. They also have a right to enjoy birthday parties. They have a right to play normally. They have a right to enjoy festivals. They have a right to eat junk food, and they also have food tantrums, and they also have food cravings. So management of type 1 diabetes is like planning a holiday package. You have to give the right package for the right family. Next slide. So caring for a child with type 1 diabetes is like choosing a mobile phone. You need to be very wise about what you choose and how you take care of the phone. Next. So the important concept that as pediatricians caring for children with diabetes, all of us must remember that the choice of the treatment depends on the right choice of insulin, the right regimen, and the right delivery device. All the three are very important to give the right care for the right child. Next slide. Yes, this is the most important slide. So it is very important that you match the carbohydrate content of the food that the child is eating and the insulin dose. If they are matched, the sugar remains normal. Whenever you give more carbohydrates and less insulin, there is going to be hyperglycemia Or the reverse, whenever you're going to give more insulin and less carbohydrates, you're going to have hypoglycemia. So I think that is the most important thing. Next slide. That is the most important thing that as parents and caregivers of type 1 diabetes, we have to remember. So whenever we have a child who is an undependable eater, and the logistic noon injection is feasible. So we have to keep in mind that basal bolus regimen is the most ideal regimen for such a child. So where you mimic the artificial pancreas, you mimic the nature's pancreas, and you give insulin similar to what the pancreas created by God would do. So it is like taking a postpaid plan for your connection. Next slide. So how is it that you're going to give basal bolus for this particular child? You're going to give a shot of insulin that is going to give basal cover for 24 hours like an insurance policy. And whenever the child is going to eat, you're going to give a bolus injection. So you're mimicking nature and you're mimicking physiology. How do you go about it? Next slide. Previous. Right. You have to decide the bolus, you have to decide the basal. So how do you decide the bolus? Bolus is decided by choosing the right insulin carbohydrate ratio. Young children have a higher insulin carbohydrate ratio. As they grow up, they have a lower insulin carbohydrate ratio. What does that mean? The child is going to require more insulin for the same food as the child grows up. This is a very important learning point. Next slide. So how do you do that? Look at the food the child is going to eat, count the carbohydrate content of the food, have a knowledge of the insulin carbohydrate ratio as shown in this slide, and give the shot. So this child for breakfast is going to eat rose milk, noodles, and Complan. You're calculating the carbohydrates, giving the dose based on the insulin carbohydrate ratio of 1 unit for 15, and giving the right dose. Next slide. If the child has 1 cup of porridge, you're going to give, which contains 15 grams of carbohydrate, you're going to give 1 unit if the insulin carbohydrate ratio is 1 for 15. What does it mean? There is no fixed dose. If the child has 2 cups of porridge, you'll give 2 units. If the child has 3 cups of porridge, you'll give 3 units. So if the child has half cup of porridge, you will reduce the dose accordingly. So there is no fixed dose. You decide the bolus based on the eating pattern of the child. And what bolus to choose? As shown in this slide, there is a cafeteria. You have to choose what is right for the child. Next slide. How are you going to, so we understood how are you going to decide the bolus? How are you going to decide the basal dose? This is a table which helps you decide the basal dose. Calculate the total daily requirement, and as per the age, give the percentage calculated as basal. For older children, they require higher basal dose. For younger children, require lower basal dose. So for example, a child who weighs 30 kilograms would require a dose of about 30 units, of which 40% would be basal. So around 8 units would have to be decided and given as basal. So once you decide the basal dose, what are you going to give as a basal preparation? Next slide. So again, you have a cafeteria. You choose what is right. As I said previously, management of diabetes is like a holiday package. Choose the regimen and choose the dose and choose the preparation. You can choose whatever you want. Every preparation has its own pros and its own cons. What is suitable for the family, you will have to decide. Next slide. So, however, in situations where the child is having a very dependable eating pattern and there are practical difficulties in giving an injection at the school, you choose a compromised regimen. How would you go about it? Next slide. So you would choose insulin to cover for the breakfast and lunch, and again for the dinner and the nighttime requirement. You would mix and give a short acting and intermediate acting in the morning and night. Next slide. So the morning shot, which contains both the regular and the intermediate acting, would cover the breakfast and the lunch. Next slide. The night shot would cover the dinner and the overnight requirement. Very important. But remember the important concept. There is no fixed dose again. You match the dose based on the carbohydrate content of the food. So the principle of basal bolus regimen is you go to the shoe shop and you choose your shoes. You go to the shop and choose your glove size for your hand. And you go to the shop and choose your cap size. Basal bolus regimen, a strict yes for all growing children. Next slide. A compromise regimen is a pre-mixed insulin giving a split mix, which is not recommended for growing children because it is like by adjusting your shoes to your foot for the shoes that somebody else has got for you. Adjusting your hand for the gloves somebody else has got for you. You give a fixed dose of insulin and command the child to eat based on the dose, which is not recommended and leads to poor glycemic control. So comparing split mix and basal bolus, the message is, even though split mix may be convenient, in the interest of the long-term health of the child, always choose basal bolus regimen. Next slide. So this is our small paper where we have showed that basal bolus therapy is indeed feasible even in a small developing country. Next slide. So to sum up, basal bolus regimen, I repeat, basal bolus regimen, never split mix or pre-mixed insulin for growing children. Basal preparation, calculate based on the weight and age of the child. Given, you can choose your preparation. It's like a cafeteria. Choose the regimen, choose the preparation, and choose the delivery device. Bolus injection is calculated based on the carbohydrate content of the food. There is no fixed dose. Whatever the child eats, count the carbohydrate and give the dose. Check, inject, eat. Check, inject, eat. Injection should be decided based on what the child is eating. There is no fixed dose, and give the appropriate bolus dose. If the noon injection is not feasible, you can give a combination of regular and NPH based on the carbohydrate content. The advantage of this is there is no noon injection at school. This is how one would initiate ambulatory care of a child with type 1 diabetes mellitus. Next slide. What is an important acute complication that a pediatrician should be aware of? With the epidemic of diabetes, which Dr. Parvati pointed out, there is going to be an important acute complication. Next slide. An important acute complication is hypoglycemia. Whenever you see a child, suppose a scenario like this, where you see a child with a sugar of 41 and child looks absolutely fine, what do you do next? It's like a low charge in a mobile phone. There are clear-cut guidelines that any CBG value below 70 is hypoglycemia. Whenever you see hypoglycemia, classify it, treat it, and think why it occurred. Next slide. So whenever you have hypoglycemia with autonomic symptoms, it's bad hypoglycemia. Whenever you have hypoglycemia with neurological symptoms like seizures or altered sensorium, it's very bad hypoglycemia. And whenever you have hypoglycemia without symptoms, it is the worst hypoglycemia. Why? Because the child doesn't know. The autonomic symptom is an insurance policy which helps the child recognize hypoglycemia early and prevent a neurological complication. Next. So it's very important that the hypoglycemia should be recognized early, and these are the do nots. Never treat low sugar with chocolate because there's going to be a significant fat component which is going to delay the rise in sugar. Never treat hypoglycemia without checking. Presumptive hypoglycemia, no. And never ignore hypoglycemia as a prank. You may be devastated. Next slide. So we understood how to recognize it, how to classify it, and the third step, how to treat it. Rule of 15. If it is simple hypoglycemia with autonomic symptoms, just give 15 grams of carbohydrate, recheck in 15 minutes, and give the next snack in 15 minutes, 15 to 30 minutes. 15 grams of carbohydrate and recheck in 15 minutes. Rule of 15 must be followed whenever you encounter a child with type 1 diabetes mellitus with hypoglycemia. Next. So, and lastly, don't forget to think why it occurred. Did we give excess insulin? Did we give less carbohydrate? Did the child play a lot that led to hypoglycemia? Is the child entering into honeymoon phase where there is endogenous insulin production? Think, and prevent the next episode of hypoglycemia. And lastly, as far as classification concerned, whenever you have hypoglycemia with seizures, it is a neurological symptoms. Next slide. Children with hypoglycemia and neurological symptoms can be treated with glucagon. Glucagon is very much available, so it's very important at least the young infants and all the emergency rooms are equipped with glucagon so that they can give glucagon even without securing an IV line. Small infants 0.5 milligram, older children 1 milligram must be given in case of severe hypoglycemia. Next slide. So this is a short summary. Whenever you see hypoglycemia, think, define it, check it, classify it, treat it, prevent it. Any CBG less than 70, hypoglycemia, autonomic or neurological. Rule of 15 for moderate and simple, and glucagon for severe. Recheck again, find out the cause, and prevent the next episode. This would be a simple approach to hypoglycemia. Some common scenarios which pediatricians encounter in type 1 diabetes: child develops an intercurrent illness, a situation like enteric fever. Remember, like a mobile phone, any illness is going to pull down the battery and pull down the balance amount. It's like roaming. So you will have to charge more, you'll have to give more balance. So how are you going to do? Look at the sickness of the child, look at the oral intake. Whenever a child has an illness, remember ketones are more useful than blood sugar. I repeat, ketones are more useful than blood sugar. If the urine ketones are large or the blood ketones are elevated, be careful. Next slide. So how are you going to handle? You have to increase, as I said previously, you have to increase the battery charge. How are you going to increase the battery charge? You're going to increase the sugar level in the body. So how are you going to? You're going to increase the energy level for the child. If the child is very sick and has DKA, child has to be treated as per DKA protocol. However, if the child is sick and has a normal intake, prefer not to put them on IV fluids, but encourage oral intake. If the intake is poor, start them on routine maintenance IV fluid. I reiterate the point here that IV fluids is not the solution for any child with an intercurrent illness. If the intake is poor and the child has ketosis, give them IV fluids. If the intake is normal, try to encourage oral intake and give extra insulin. So this is how you'll pull up the charge. Next slide. So you have to give insulin extra. So how are you going to recharge? You have to give a dose which does not cause hypoglycemia, which does not cause acidosis. So how are you going to give? Next slide. So this is a simple sliding scale that can be adopted. Based on the sugar value, short, small doses of bolus doses can be given. And these doses will avoid hypoglycemia, will avoid slipping of the child from ketosis into acidosis. Multiple doses of short-acting insulin, and never skip basal insulin. The message is never skip basal insulin. Next slide. So never skip basal insulin, give more frequent bolus dose, increase the check ketones, and be in regular contact with the team. Whenever you find persistent vomiting, large ketones, and altered sensorium, go and consult the hospital. Surgery. Surgery is one state where the child can slip into DKA. As a pediatrician, when we admit a diabetic child for a surgical procedure, remember to take some basic precautions. If it's a simple procedure, next slide. If it's a simple procedure, next slide, sir. If it's a simple procedure, remember, if it's a minor procedure, no IV fluids, no modification in the subcutaneous insulin. Next slide. Why? Because these children are on basal bolus regimen. So your basal is always covering these children. So one skipping of one bolus, you can give a correction dose in the next bolus injection. Very simple. Whenever you have children on basal bolus regimen, you just need to skip that particular dose, because you remember your insurance policy of basal is always covering, and avoid IV fluids. Next slide. However, if you're looking at a major surgery, next slide. Major surgery, you're going to have low, like a mobile in roaming. Your battery charge is going to go low, your balance amount is going to go low. So you need to give IV fluids, you need to give IV insulin. Next slide. So you need to put them on maintenance fluid, and you have to maintain them on maintenance fluid. Next slide. And how are you going to recharge? You're going to give them IV insulin. So rough remembering thing is, you can start them on 1/4 of the DKA dose. Generally, we tend to start children with DKA on 0.1 IU per kg per hour. So probably 1/4 of the dose you can start these peroperative children and adjust based on the CBG values. Next slide. And last scenario, where you're going to have a type 1 diabetic child who wants to run a marathon race. How would you like to adjust? The next slide. Remember, major exercise, again like a mobile, it's one situation where your battery charge is going to low, but your balance amount is going to remain. So they require more checks, but less insulin. So whenever a diabetic child is going in for an unaccustomed exercise, never inject in the lower limb, reduce the doses, increase the sugar checks. Next slide. So give extra carbohydrates, a 15-gram snack for every 30 minutes of marathon. And always remember to check at night to prevent nocturnal hypoglycemia. I think the diet to be taken will be discussed by Cheryl. A quick summary: sickness, golden rules, check ketones, IV fluids only if the oral intake is poor, use sliding scale, check more, and watch for danger sign. Physical activity, more carbs, less insulin, watch for delayed hypoglycemia. Minor surgery, just skip the bolus dose. Major surgery, IV fluids and IV insulin. IV insulin will be 1/4 of the DKA dose. Next slide. And the last aspect of care of type 1 diabetes mellitus, how are you going to service your mobile? Next slide. An informative logbook. I think every visit, please reinforce to the parents to maintain an informative logbook. Next slide. A good logbook is equal to good diabetes care. A good self-monitoring blood glucose frequency is equal to good diabetes care. That's the SMBG frequency. Check more and adjust the doses should be encouraged to the family in every visit. Next slide. And HbA1c. It's very important that it's like maintenance. It's like an insurance policy. You will have to check your HbA1c and assess the control at every 3 months. And HbA1c below 7.5 is a predictor of a very, very remote possibility of complications. So it should be ensured that all of them try to maintain an HbA1c below 7.5%. Next slide. And screen them for long-term complications. Remember, puberty is an accelerator of complications. So whenever you have children with diabetes in puberty, you screen them at 2 years. Whenever you have pre-pubertal children, you screen them at 5 years. Screen them for microvascular complications, macrovascular complications. Microvascular complications, kidneys do a nephropathy, eyes do a fundus screening, and foot do a physical examination. Macrovascular complication, a lipid profile every 5 years and a blood pressure. And always don't forget to look at their local sites for any local lipodystrophy and hypertrophy, especially if they don't rotate the sites. And maintain a very good growth chart. A good growth chart is like as good as an HbA1c to tell you if the child is having good diabetes control. Normal growth is equal to excellent diabetes. Next slide. An abnormal growth is a sign of a poorly controlled diabetes. Growth faltering. The growth chart is a mirror of care that you are giving these children. Whenever you have poor growth velocity, always think about hypothyroidism. Next slide. And whenever you have poor weight gain, think in terms of associated problems like celiac disease. Next slide. An important thing is to screen them for associated comorbid conditions. A thyroid profile should be done at diagnosis and annually thereafter. A celiac disease screening should be done at diagnosis and 2 yearly thereafter. Very important that you screen these children for comorbidities and you treat them for an optimal health of these children. Next slide. To sum up, care of children with diabetes is very important, like maintaining a mobile, a proper logbook, 3 monthly HbA1c, the mirror of the care you are giving, a proper growth chart and SMR, screening for local, microvascular and macrovascular complications, and comorbidity screening is an important pillar in the care of children with diabetes. A word about CGMS. CGMS, self-monitoring of blood glucose, is like a trailer of a film. It's just tell you what is lying inside. CGMS is an actual film. It is really going to give you a real-time measurement of how the blood glucose of the body is. It measures the interstitial glucose level and gives you an actual film of how the body's sugar is. Easily available, increasingly being recommended by bodies for usage. Next slide. Pump. Pump is nothing but an improvised delivery device. So I think it's very important that you remember the masala dosa that you have, whether it's made at home or whether it's made in a roadside shop or whether it's made in a 5-star hotel, depends not on where you eat, but on how the preparation of the food. Similarly, the insulin that you give, the principle and concept of basal bolus is very important. Whether it is given by a syringe, whether it's given by a pen, or whether it's given by a pump, is secondary. The concept of basal, the concept of bolus is very important. Pump, yes, it has its own lot of advantages where it does give a good quality of life. It is an improvised basal bolus regimen where you can adjust and give a very good glycemic control, but that does not say that it is a basal bolus is gone. It is an improvisation of basal bolus insulin regimen. Next slide. So this is a pump where you use an infusion set and a reservoir where it is kept, and it gives a continuous delivery of basal and it gives boluses whenever you are going to eat. So just I'm summarizing whatever I have told. Choosing insulin regimen caring for the ambulatory child with diabetes is like choosing a right mobile phone. Never split mix, never fixed doses. Only basal bolus, only basal bolus. Adjust insulin for food, never food for insulin. Choose the right basal based on the weight of the child. Choose the right bolus based on the carbohydrate content of the child, which Cheryl is going to talk next. Teach the family carbohydrate counting. What the child eats, you bolus, never fixed doses. If there is a problem in giving injection at school, you can give a combination of regular and intermediate acting so that the noon injection can be avoided. Again, there is no fixed doses. Adjust for the carbohydrate content of the food. Next slide. Whenever your charge is getting low, check less than 70, see whether it is autonomic or neurological. Rule of 15, 15 grams of carbohydrates, recheck in 15 minutes, find out the cause and prevent the next episode. If it is severe hypoglycemia, give glucagon. In sickness, check more, check ketones, no IV fluids for all children. Physical activity, more carbohydrates, less insulin, more checking. Minor surgery, just skip that bolus, and major surgery, top up with IV fluids as well as with IV insulin in a lower dose. A good logbook, a good growth chart, a good HbA1c is a pillar and a mirror of the care you are giving. Pre-pubertal children, 5 years. Pubertal children, 2 years. Screen for microvascular and macrovascular complications. Never forget to screen them for comorbid conditions like hypothyroidism and celiac disease at diagnosis and annually thereafter. Thank you very much.
Thank you, Dr. Hindra. That is very, very concise. And the mobile phone simile was something that I think will take very well. Now, we know that these children are probably in the families to reorganize the dietary habits if a child is diagnosed with type 1 diabetes. Not the child alone. Family needs to change. There's no better person than Cheryl Salis to show us the way to handle this very important aspect of the care of these children, the medical nutrition therapy. And Dr. Cheryl Salis has got 20 years of clinical experience as a dietitian and diabetic educator, working closely with type 1 diabetic medicine, with diabetes mellitus children. The registered dietitian, certified in diabetes education, diabetic educator and insulin pump specialist, and a founder of the Nurture Health Solutions, which is pioneering. She's authored a book recently on diet and diabetes simplified, and nutrition basics in carb counting. She's the co-author of Purple Book of FSSI AI, and has contributed a chapter on diabetes in the Clinical Diabetes Manual IDA and chapter in the current topics in nutrition. She's selected by the ISPAD at Boston in 2019 for special training in research in type 1 diabetes. Courses are in visiting faculty of various education institutions. Done lectures all over the world actually. Features an expert nutritionist in the TV shows and is a speaker of several local, national, and international conferences. Reviewer of Journal of the American Academy of Nutrition and Dietetics. Over to you, Cheryl, for your.
Thank you so much, Dr. Jason, for that kind introduction. And it's a tall task to speak after Dr. Parvati and Dr. Hemchand. Enjoyed your sessions thoroughly. My topic is on medical nutrition therapy in type 1 diabetes. And the outline of my presentation is macronutrient recommendations in type 1 diabetes, carbohydrate counting, synchronization between types of insulin and meals, protein and fat counting. Next. So type 1 diabetes meal planning is very, very different to adults having diabetes or pre-diabetes. The goals of meal planning in type 1 diabetes, we have to ensure that they're well-balanced meal, keeping cultural preferences and routine in mind. We have to ensure that we're giving adequate energy and nutrient intake. It's a carbohydrate controlled meal plan that promotes normoglycemia, prevents hypoglycemia. We try and keep the HbA1c close to 7.5 to 7%. Ensuring that there is no hypoglycemia, at least 70% of the time in range, prevention of diabetes ketoacidosis and complications, ensuring that we're giving all the nutrients in the right quantity, and let me emphasize quality. The initial weight loss at time of diagnosis must be restored with adequate energy intake. And with type 1 diabetes, we may also see children with hypothyroidism and celiac, and therefore it's very, very important to plan the diet accordingly. Now, when it comes to carbohydrate recommendations, and of late, we've been coming across many parents who come and ask us that if we have to give insulin for carbs, and why not remove carbs completely from the equation. And a lot of people want to give their children a ketogenic diet or a low carbohydrate diet. However, the ISPAD guidelines have clearly stated that you should not restrict carbohydrates in children or adolescents in type 1 diabetes, as they can be nutritionally inadequate, result in growth failure, and increased risk of disordered eating behaviors. And therefore, it's very important to plan the carbohydrate basis, their age, gender, etc. Now, what are the recommendations from the ISPAD? It's 45 to 50% energy coming from carbohydrates. Very important is to focus on high quality carbohydrates, inclusion of fiber-rich foods, low GI and low GL foods to minimize glycemic excursions and improve dietary quality. Now, this is extremely important, and we tell parents of children that this is the same diet that we would give a child who does not have diabetes as well. Because today we're talking about healthy eating. We're seeing a lot of children with even type 2 diabetes or pre-diabetes or hyperinsulinemia coming to our clinics at a very, very early age. Now, protein is a very, very important macronutrient. And we know that the moment we add protein to the diet, it helps to blunt the glycemic response. It gives better satiety. It prevents late hypoglycemia. And therefore, at least 20% of energy coming from protein and 50% from good quality protein. Next. Now, fat recommendations. Why we are lowering fat, the carbohydrates. Now, the START study has clearly shown that we Indians consume at least 65 to 70% of calories coming from carbohydrates. So if we're going to lower to 45 to 50%, then we have to increase a macronutrient to meet our energy requirements. And therefore, we increase the good quality fat. So reducing the saturated fat, but improving the MUFA fats in the diet and the PUFA fats. So MUFA fats works very well because nuts are a source of MUFA fats. Your seeds are a good source of omega-3 and healthy fats, and therefore they are also low in carbs and work very well, especially when you're not giving insulin during the mid-meal snacking. Now, the conventional method was feeding for the insulin. We always worried about hypoglycemia, and therefore we have to force feed the child. Today, like Dr. Hemchand rightly said, we give insulin for the food. So you eat less. If the child is less hungry, you give less insulin. Child is more hungry, he takes more insulin. And therefore, carbohydrate counting becomes extremely important because children may eat different meals. One meal will have more carbs, another meal could have lesser carbs, especially when they have to attend birthday parties, they're going for a picnic, they're going for a wedding, and therefore it gives them a lot of flexibility. Next. Now, though this approach gives them a lot of flexibility, however, we have to be ensure that this, sometimes they take this to their advantage, and every day they would be snacking on unhealthy foods and just taking insulin because they think that I take more carbs, I can take more insulin. So therefore, it has to be educated that we have to be very, very cautious or careful when we are counseling about carbohydrate counting. And therefore, we have to ensure that the total energy and carbohydrate intake and timing of the meals is maintained to prevent excessive weight gain. Now, principles of healthy eating is very important, and that's why in our clinic we have these food plates which we actually use for counseling, and it's a beautiful concept because it actually helps in educating the parents as well as the children on the importance of eating a balanced diet. So half your plate is your vegetables, 1/4 of your plate protein, and 1/4 of your plate is your cereal, millet, and starch group. So that way you have a very balanced diet, ensuring that you have all the food groups as well as the macro and micronutrients. So the principles of healthy eating is what we educate first, and then we move on to carbohydrate counting. So it becomes very easy for the parents to implement it into practice. Now, like Dr. Hemchand said, that though we have most of our patients on basal bolus regime, we may still have or come across patients who are on a pre-mix insulin. However, very important to know is that we cannot do carbohydrate counting in patients who are on pre-mix insulin regime. Therefore, it's very important to synchronize the insulin action with food. There has to be consistency in terms of carbohydrates that are eaten at each meal as well as the timing. Otherwise, there can be a hyperglycemia or hypoglycemia. And therefore, carbohydrate counting cannot be practiced on patients who are on a premix insulin regime. Now, why do we count carbs? Carbs have the greatest short-term impact on your blood glucose levels. They get converted to glucose within the first 2 hours of eating and have a direct influence on your post-meal blood glucose levels. Like I mentioned to you, our protein and fat. This helps to blunt the glycemic response post-meal, as well as it gives you more satiety. However, if you eat protein and fat in large amounts, they will also contribute to the blood glucose rise, not immediately, but after 3 to 4 hours. However, our home cooked meals are not as high in protein and fat to make a major difference to your post-meal levels. And therefore, we count carbs, and counting carbs gives us an accurate guess of how the blood glucose level is going to rise after a meal or snack. Next. So carbohydrate counting is the key to maintaining tight control over blood glucose levels. Now, there are different opinions on when should you start carbohydrate counting or educating the parents about carbohydrate counting. At our clinic, and also as advised, by the guidelines of ISPAT, they've clearly said that you should start carbohydrate counting at diagnosis. Otherwise, it's very difficult for the parent or the children to unlearn and then relearn. So therefore, we start carbohydrate counting at diagnosis. We start with the principles of healthy eating, and then we move on to carbohydrate counting. Now, very important is we eat food. Parents or children do not understand, what is carbs, what is protein, and what is fat, and therefore, helping them recognize the carbohydrate containing foods, the low or the non-carbohydrate containing foods is very important. And therefore, there is a book that I have written, which is on carbohydrate counting for Medtronic. And there's another book that I'm working on with ISPAD, which is going to have a lot of carbohydrate counting foods for the Indian population. Then we help them in educating them to read the food labels, because today a lot of children eat out of packets, and they may think that this product is sugar free and therefore it has got no carbs, and therefore we educate them on reading food labels. Use of scales, now very important, we ask parents to invest in food measuring, the weighing scales, as well as you get these cups, so it's very, very easily available anywhere in India. So basically these measuring cups are a very, very good tool. So we educate them that suppose if they're having 1 cup of rice, now this one big cup of rice has got 30 grams of carbs and it weighs around 130 grams. So it's very easy for them to estimate and take insulin accordingly. And use of resources. Today you have a lot of apps as well as books that they can refer to. And we ask them to do their pre-meal blood glucose readings, count the carbs, and then check their post-meals 2 hours and then 4 hours to see if they've come in target range. That way they know that the insulin to carb ratio is working well. Next. Now, these are the foods which contain carbs. So this is the education that we give them. And which foods, like biscuits have got carbs, your rotis have got carbs, rice, poha, upma, all your dosa, idli, even your pulses have carbs. So very important is to educate them that which foods will need insulin. So all the foods that are shown here, because they think that jaggery and honey is safer than sugar, and therefore they will not take insulin for a food which has got jaggery or honey. However, the carb content is similar whether you're taking sugar, jaggery, or honey, and therefore they need education on this. This is what is 15 grams of carbs, but each child will require a different, will have a different insulin to carb ratio. For example, like Dr. Hemchand showed in his slide, a child could require 1 unit of insulin maybe for 30 grams of carbs, whereas another child would require 1 unit of insulin for 15 grams of carb. And therefore, this is even the book, these are pictures from the book. So basically, even if you look at dal, because a lot of people think that lentils are protein or dals have only protein and therefore do not take insulin for their dal or for the sprouts or the chana that they're eating. However, it's very important to educate them that even dal has got carbs. And if I take half a cup of dal, it has got 15 grams of carbs. Next. Now, this is what I had already mentioned, because a lot of people, you tell them to take yogurt, they'll go to the market and buy a flavored yogurt. And then they wonder why is the blood glucose going high. And therefore, we teach them on, reading the food label that the product could be labeled as a sugar-free product. However, it does not mean that it is carb-free. And therefore, you have to read the food labels and count carbs. Now, what are the low-carb foods or what are the no-carb foods? For example, all your non-veg foods, whether it's egg, fish, chicken, all of them have got no carbs. So they are no carb foods. And there are foods such as your vegetables, especially your non-starchy vegetables. So potato is not a low carb food. A potato, 100-gram potato will have roughly around 15 grams of carbs. However, all your non-starchy vegetables, your green vegetables, your leafy vegetables, nuts, paneer or cottage cheese, soya bean, cheese, buttermilk, all these are considered to be low carb foods. So these become a very, very effective tool, especially when the child is hungry in between and wants to eat something and you're not giving insulin. So these are the foods that we ask them to opt for. However, we also educate them to choose low saturated fat options. Now, insulin to carb ratio. Now, how do we come to this? There's a very simple formula. If they're on regular insulin, it's 450 divided by total daily dose. If they're on a rapid acting insulin, it's 500 divided by total daily dose. And 1 unit will cover that many grams of carbohydrates. For very young children who are less than 5 years of age or require less than 10 units of insulin per day, 300 to 450 rule may apply. But however, this is just to start. You will have to still ask the children to check their pre-meal blood glucose levels or do the CGMS, check what the glucose levels is before starting the meal, give a carbohydrate counted meal, and then accordingly give the insulin to carb ratio, and then check the post-meal. Now, very important is to note that the children could have a different insulin to carb ratio in the morning, maybe because of the dawn phenomena, and in the evening because they are more active, they would have they would require lesser insulin for the same amount of carbs, and therefore it's very important to maintain a logbook, check the glucose levels either on a CGMS or by SMBG. So a lot of factors which would influence this. We've seen that the time when examinations are on, because the physical activity is not there, the children need more amount of insulin. Also because they're sleeping late, they're eating more often because they're keeping up late, during the menstruation, during puberty is the time when they require more amount of insulin. So they have to rule out all these factors. Weekdays and weekends are very different, and therefore when we take their recall as well, we look at what are they eating on the weekdays, what are they eating over the weekend, what time they wake up, what are their play times, and we plan the diet accordingly to ensure that even if they're going for an activity, they don't go into hypoglycemia, and therefore we give them carbs just before their activity. Next. And today you have the SMBG, you have CGMS, which gives us a lot of data in terms of how is the glucose responding, and it becomes very easy while educating the parents and the children to teach them or show them that if they're eating a certain food, how is it influencing their blood glucose levels, and how they could tweak the meal to ensure that their blood glucose levels are in range. So basically we look at, the time in range, and this is one of, the reports, and this really gives us a lot of data, and it really is a very useful resource to us while we are planning diets and we are adjusting the insulin to carb ratio. Next. Now, every meal plan, every insulin will call for a different meal plan. It's not a one size fits all approach. For example, if you have a child who's on a regular bolus with a basal analog, there, when the child is on regular in the morning, regular at lunch, and regular in the night, it will call for 6 meals, because regular peaks up after 2 to 3 hours, and therefore a mid-meal snack can be kept which has got carbs. For example, if the child is going to school at 8, again at 10 o'clock the child can take a snack which has got carbs. At lunch, a carb counted meal, and then again in the evening, a carb counted snack, then dinner, and very important for a child who's on a regular acting insulin, will require a bedtime snack. Next. Now, for a child, we have some children who are in this regime, because it becomes very difficult. The children eat by 8 and then go to sleep by 9 o'clock in the night. And therefore, if the child is on a regular insulin in the night, then keeping awake to have that bedtime milk or bedtime snack becomes extremely difficult. So if a child is on this regime, where the child is on a regular acting insulin in the morning, regular acting insulin at lunch, and rapid acting at dinner, this does not call for a bedtime snack. So a bedtime snack is not necessary if the child is on this regime. If the child takes a bedtime snack, then the fasting blood glucose levels will be high. Now, this is the third regime, when a very commonly used regime, which is when the child is on rapid acting insulin 3 times a day. So rapid acting insulin in the morning, rapid acting insulin at lunch, and rapid acting insulin at dinner. Now, here, you can only give the meal after the rapid acting insulin, which has got carbs. For example, breakfast, lunch, and dinner should have carbs as per the insulin to carb ratio. However, if the child is having a snack at mid-meal, like at 10 o'clock or maybe in the evening at 4 o'clock, then the child will have to take the child will have to take a low carb snack from the slide that I showed you. For example, nuts, a bowl of curd, maybe some soya nuts. It could be an egg or a chicken salad. So these are the options that are given as low carb options in between. And if the child wants to eat a snack which has got carbs, for example, the child wants to eat a sandwich or wants to eat a wrap or wants to eat a dosa, then he will have to take insulin according to the carbs that is consumed. However, we also educate parents and children to keep a gap of at least 4 hours to prevent insulin stacking. Now, effect of protein and fat. When protein and fat is taken in high amounts, for example, if fat taken, more than 20 grams per serving of the meal, or if the protein is more than 25 to 30 grams per serving of the meal. For example, if the child is having a pizza outside, which has got a thick crust pizza with a lot of meat on top, a lot of paneer on top, this will definitely influence the blood glucose readings. And we see that the sugar readings tend to run high for a longer time. Even when they've had something like a butter chicken or a butter paneer or something like that, which has got high amount of fat with naan, then the blood glucose levels tend to be on the higher side. And therefore, there taking additional insulin is recommended. Next. And therefore, CGMS becomes very useful. Again, the guidelines by ADA as well as the ISPAT guidelines have clearly said that first you educate about carbohydrate counting and then move to the dietary protein and fat counting, and therefore accordingly give the insulin bolus. Now, when a child is on an insulin pump, there is a feature on the pump where you can take different kinds of bolus. So depending on what kind of meal if you're eating, for example, you're eating a high GI or a moderate GI meal, you take a normal bolus, which is like if you're having a dosa or having idli, you take a normal bolus. But if you're having a meal which has got carbohydrate, protein, and fat, then you can do a dual wave bolus, which is the next. And if the child, we've got certain, I recently came across one type 1, she's around 24 years old with gastroparesis. Over there, square wave bolus works very well. So depending on the situation, you can decide what type of bolus the child takes. For example, if the child is having a PISA and if the child is on an insulin pump, there we could tell the child to take a dual wave bolus. So you take some amount of insulin just now and some amount of insulin which is spread over 3 to 4 hours, and that works well, especially when the fat releases the glucose later. Next. So key take-home messages that type 1 diabetes management calls for a team approach. As I mentioned, it's not a one-size-fits-all. It's very important to work closely with the patients, the caregivers, the doctor, the qualified dietitian, an educator, and a psychologist. And again, when we're talking about dietitians, there are very few dietitians in India who are trained to see children with type 1 diabetes. And therefore, it's very important to refer the patient to a dietitian who's trained in managing children with type 1 diabetes. Every child is unique, and therefore the meal plan has to be personalized to ensure that we're ensuring growth and development, making sure that we're taking care of activities, social events, matching the food to the insulin and routine. And education from time of diagnosis on carb counting, and then stepping up to protein and fat counting. On a regular day, you don't really need to do protein and fat counting. However, when they go out to eat or they're at the birthday party, then definitely their protein and fat counting come into play. Next. So thank you so much for your patient hearing. All that I've spoken is in my book, Diet and Diabetes Simplified, and it's available on Amazon, Kindle, and Flipkart. Thank you.
Thank you so much, Cheryl, for that very, very lucid presentation. I don't think there are many chat questions. So as the questions come in, we will first do the quiz before we do the questions. Shall we do that?
Yes. Yes.
Isn't it? So we'll do the quiz. So if there are PGs around and senior pediatricians also to take part, it is a area which I think all of us need to know a lot about. So the quiz questions start now. We start with the first question, which says that the biochemical criteria for diagnosis of diabetic ketoacidosis are all except hypoglycemia, glucose usually more than 200 milligrams per dl, ketonemia, serum ketones more than 3 millimoles per liter, large ketonuria, venous pH less than 7.2, and serum bicarbonate less than 15. Second question, the clearest evidence of a role for viral infections in type 1 diabetes is seen in acquired rubella infection, live virus rubella immunization, enteroviral infection, congenital rubella syndrome, mumps infection. Subjects with type 1 diabetes mellitus have evidence of celiac disease in 5 to 10%, 11 to 15%, 16 to 20%, 21 to 25%, and 25 to 30%. All are true about sick day management of type 1 diabetes mellitus except never skip basal insulin, check blood urine ketones, complement glucometer readings, early IB fluids prevent DKA even if oral intake is good, persistent elevation of ketones warrant hospital visit, blood ketones are more sensitive than urine ketones in early diagnosis of DKA. Continue insulin infusion and treatment of DKA without causing hypoglycemia, glucose must be added to the infusion. It's recommended that glucose be added as a 5% solution as serum glucose has decreased to less than 100 milligrams per dl, 150 milligram per dl, less than 250 milligram per dl, less than 70 milligram per dl, less than 100 milligram per dl. Cerebral edema complicating PKA remains a major cause of morbidity and mortality in children with and adolescents with type 1 diabetes mellitus. All the following are true except early bolus administration of insulin is a risk factor. High volumes of fluid is a risk factor. Clinical diagnosis of using the Muir's criteria has a sensitivity of about 90%. Neuroimaging is important in the diagnosis of edema and primary cause of increased mortality and decay all over the world. Guidelines suggest that pre-pubertal type 1 diabetes mellitus patients should commence screening for retinopathy at diagnosis, 1 year after diagnosis, 3 years after diagnosis, 5 years after diagnosis, and 10 years after diagnosis. Guidelines suggest that diabetic patients should commence screening for celiac disease at diagnosis, 1 year after diagnosis, 3 years after diagnosis, 5 years, or 10 years after diagnosis. Diabetes and thyroid disease coexist. The possibility of autoimmune adrenal insufficiency should be considered. It may be heralded by all of the following except increased insulin requirements, increasing pigmentation of the skin, salt craving, asthenia, postal hypotension. Eight-year-old girl presents with weight loss and polyuria. GRBS is 256 milligram per DL. All of the following tests are indicated in the diagnosis except arterial blood gas, OGTT, serum acetone, HB1, HbA1c. All are true regarding insulin therapy in type 1 diabetes mellitus, except all kids should be initiated on bolus insulin regimen. Insulin requirement of in unit per kg per day increases with age. Fixed dose are ideal for young children to minimize errors. Intensive insulin therapy leads to improved glycemic control. Hypertrophy is common complication of rotation is inadequate, except all are true regarding insulin therapy in type 1 diabetes, except all the following are low carbohydrate foods except 125 grams of yogurt, 30 grams of raw pulse or dal, 20 grams of raw soya bean, 50 grams of cottage cheese, boiled egg. All are true in nutrition management of type 1 diabetes as per SPAT guidelines, except carbohydrate should approximate 50 to 60% of energy intake, protein 15 to 20% of energy, fat less than 35% of energy, fiber intake in grams about 2 years each, age in years plus 5, replacement saturated fat with unsaturated fats. The last one is a child with type 1 diabetes develops excessive sweating. Blood glucose check by the parent is 45 milligram per DL. All of these can be administered for correction except 3 teaspoons of sugar or glucose, fruit juice, sugar candy, honey, or chocolate. Thank you. So while uh, doctors, Dr. Pramod and uh, others are trying to find out who the winners are because there's so many people so many pages of answer questions. We will have the answers explained by our faculty. First question. I think I'll take over. First is Parvati.
Yes, sir.
Please answer the
Slide.
question. Slide is on, no? Slide is not on?
I'm not able to, I'm not sure whether others are able to see.
Okay, then I'm sorry.
Not on. It's not
Okay,
on.
sorry.
So the first question was on the definition of diabetic ketoacidosis. So basically, I had mentioned diabetic ketoacidosis. So it's very important in clinical scenario. It's very important to differentiate between diabetic ketoacidosis.
You seeing the slide now?
Yeah, yes, sir.
Yeah.
It's fine. So basically, emergency department, you can encounter a lot of stress hyperglycemia, especially when the child has a severe illness, has undergone trauma or surgery. There's a chance for a stress hyperglycemia. So how would you define a diabetic ketoacidosis? Is very important. The blood sugar should be more than 200. The serum ketones are elevated. The serum ketones are more sensitive in picking up a diabetic ketoacidosis than urine ketones. Earlier, we used to check more of urine ketones. Now we rely more on serum ketones for the diagnosis of DK as well as on the resolution of DK. So the three main criteria are blood sugar more than blood ketones or a large ketonuria, and also you have acidosis, that is either pH is less than 7.3 or bicarb is less than 15. And this is how you classify the severity of DK. You have mild, moderate, and severe. Blood pH less than 7.3 is mild, less than 7, severe is less than 7.1, and based on bicarbonate, it is classified as mild if it is less than 15, moderate is less than 10, and severe is less than 5. So in your answer, the answer is D, which is not true. The venous pH less than 7.3 is classified as diabetic ketoacidosis. It's very important to be aware of this definition for a proper diagnosis. Yes, sir.
Next, Dr. Hemchand, the clearest evidence. Yeah,
the clearance evidence of a role of viral infection in type 1 diabetes, as all of us are aware of, it is congenital rubella syndrome, because the clearest evidence is in congenital rubella syndrome. Prenatal infection with rubella is associated with beta cell autoimmunity up to 70%, and development of overt diabetes up to 40%. The postulation is the association with HLA-DR2 and DR3, which is supposed to be the intervening factor, and so the association between congenital rubella and type 1 diabetes what establishes the role of viral infection in the onset of type 1 diabetes.
D.
Yeah, the third question, type 1 diabetes children have what percentage have evidence of celiac disease? So we should be aware that the two autoimmune diseases that should be type 1 diabetic children, one is thyroid disease, autoimmune thyroid illness, and the second one is celiac disease, and the incidence is around 5 to 10%. So the choice is A, and it's very important to screen for them at diagnosis, and then if it is negative, probably at 2-year intervals. Screened at diagnosis as well as yearly a thyroid screening should be done. So these are the two common autoimmune diseases that are screened in type 1 diabetes.
Right. What is true about sick day management, except I think most of you have answered it right. Never skip basal insulin, always check ketones. Persistent elevation of ketones, check, go to the hospital. Blood ketones are more accurate. Early IV fluids is not recommended, because see what happens is when the oral intake is good, it is always recommended that they have more carbohydrate-rich food orally itself rather than parenterally. So early IV fluids is not recommended in sick days unless the oral intake is poor.
The fifth question, to continue the insulin infusion and treatment of DK without causing hypoglycemia, glucose must be added to the infusion. So it is recommended that a 5% glucose solution is added when the serum glucose falls below 250. So in the management of diabetic ketoacidosis, it's very important that we don't reduce the insulin infusion unless the acidosis has reverted. So there is a chance for reducing the insulin infusion once you see the blood sugar is dropping down. So if the blood sugar is dropping down, what you have to do is titrate the IV fluid. So when the sugar is less than 250 to 300, as per ISPAD guidelines, you can add a 5% solution of glucose. Yes. So the answer is C.
Right. Cerebral edema, I think this most of you have got it right. Remember, IV insulin bolus should never be given. Overhydration should never be done. And doing a CT to diagnose cerebral edema is not warranted. Cerebral edema is usually diagnosed clinically. Clinical diagnosis is more accurate to make a diagnosis. And the first sign of cerebral edema, start on anti-edema measure. And that is made on the bedside by monitoring of the GCS rather than by doing CT.
Seventh question, the guidelines suggest that pre-pubertal type 1 diabetes patients should commence screening for retinopathy. Dr. Hemchand has clearly mentioned in his presentation. So pre-pubertal, usually after 5 years of duration, and pubertal children, usually after 2 years. Next question, sir.
Celiac disease, as mentioned previously, important associated autoimmune problem. And people tend to think that celiac disease is a disease of the northern part of our country, but it is not true. A lot of South Indian families also tend to have celiac disease, and they should be screened, especially a high-risk population like type 1 diabetes should be screened at diagnosis and 2 yearly thereafter. At diagnosis is the right answer.
2 years interval of not.
The ninth question, when diabetes and thyroid disease coexist, the possibility of autoimmune adrenal insufficiency should be considered in all the following scenario except. So usually, as I said, the two common autoimmune diseases that are screened are thyroid disease and celiac. But when you have a recurring hypoglycemia in a type 1 diabetic child, it's very important to think of a possibility of an adrenal insufficiency. So all the choices except the first one, increasing insulin. So usually there'll be a decreasing insulin requirement and hypoglycemia when you have a cortisol insufficiency that is setting in. All the other features are characteristic features of adrenal insufficiency. Weight loss, hyperpigmentation, etc. could be associated. So the answer is increasing insulin requirement. You would have a reducing insulin requirement.
Remember, insulin and cortisol are like two sides of the balance. Whenever your cortisol level goes down, insulin goes up. Insulin comes down, cortisol goes up. So that is something which you have to remember. So whenever you have insulin resistance, think of Cushing's, think of steroid therapy. Whenever you have low cortisol, think in terms of lower insulin requirements. So this is a child, I think most of you have answered it right. Weight loss, classical symptoms of diabetes. Why would you push this child into DKA by giving a load of 75 grams of glucose? That should never be done. So I think most of you answered right. OGTT is not warranted when there is overt diabetes. When WHO defined diabetes, it said either of the three with symptoms of diabetes. So there are symptoms, random sugar is more than 200. You should not push the child from a probably a simple hyperglycemia or ketosis into DKA by giving a glycemic load without treatment. So the answer is OGTT. Right, this I think most of you have answered it right. Fixed doses are ideal. No fixed doses are never given. Always check, inject, and eat based on the carbohydrate content of the food. There are no fixed doses for children.
Cheryl?
Yeah, so all the following are low carbohydrate foods except, like I mentioned, raw pulse or dal. 30 grams of raw pulse of dal will give you around 15 grams of carbs, and therefore it is not considered a low carb food because we consider a food a low carb food only if it has got less than 5 grams of carbs per serving, and therefore dal is not considered a low carb food. All are true in the nutritional management of type 1 diabetes as per the ISPAT guidelines, except I think most of you answered this right. It's carbohydrate should be 45 to 50% of energy, fat less than 35% of energy, whereas where saturated fat is kept to less than 10%, we increase the MUFA fats and the omega-3 fats, protein 15 to 20% of energy. This is the ISPAT 2018 guidelines. A child with type 1 diabetes develops excessive sweating. Blood glucose checked by parent is 45 milligram per DL. All of these can be administered for correction except the right answer is E, which is chocolate. A lot of children look forward to hypoglycemia is because they know they can get a treat. However, chocolate has got fat and it will not release the glucose immediately. And we need something which is a fast release, and therefore pure glucose or sugar dissolved well in water is recommended, or even a sugar candy at this time. Definitely not chocolate ice creams or any Indian sweets or cakes. Thank you.
Okay, so we've come to the end of that quiz. If there are any questions from anybody, there's no question in the chat box as such, but see, we'd like to know, what is your experience with the psychiatric complications? How do you maintain them motivated and psychologically in proper shape throughout their adolescence? Dr. Parvati or Dr. Hemchand?
I think that is the most challenging aspect is not getting the first rank, but getting the first rank in every exam. So I think it is something like that. So it's very difficult, and I think what really helps is support groups. When parents get together and they motivate each other with their achievements, their HbA1c, the achievements of their children, the bright things done by their children, I think that motivates another family to follow the footsteps of the previous one and do a good control. I think peer group support is the only thing which keeps these families motivated.
Do you have these picnics, the diabetic picnics, where these children go by themselves without parents? And is that happening in Chennai? Parvati, are you doing it here, or Cheryl, are you experienced with that?
Yes. We have it in
do
Mumbai.
it with the families. Ours being a private setup, we don't encourage, because of the legal worries, we don't want to take them alone. But with the families, yes, they go together and they kind of have outings and kind of interact with each other and motivate each other.
Also, there are a lot of other support groups. Cheryl must be, and Dr. Hinchin must be aware. There are a lot of type 1 diabetic celebrities who are coming up with their vlogs. For example, Jas Sethi, who's a well-known type 1 diabetic, and from Kerala, I think Indu Thambi. They're all doing very good jobs motivating these type 1 diabetic kids by their experiences and sharing even how they manage the hypoglycemia. A lot of aspects of type 1 diabetes from their perspective.
How do you improve the self-esteem of these children? Because they may be good at a lot of other things. I have a child who's a ranked player in badminton, national badminton scene in India, and her insulin requirements are much less than the others. I mean, the regular workouts. Do you increase that? Himchan? Unmute.
See, improving the self-esteem, I think, as I said previously, it is just the peer support which they can get is the only thing which is going to improve the self-esteem. I don't think there is anything else that we can offer to improve the self-esteem, and we have to motivate each other.
I think I'd like to add to this. So I think from what I've seen with the children who've been diagnosed maybe 20 years ago to today, I think telling them that, everything is fine. It's just that the insulin hormone, insulin is, not there, which they need to take, and they can lead a normal life. Because in the past, we used to have a lot of restrictions, even when it came to food. When anybody came to us, we used to give them a big list of what not to eat. But today we educate them that you can eat everything, provided you take insulin, and you take insulin in the right amount for the food you're eating. So I think that really helps, because they do not see themselves as different to other kids, and they can attend birthday parties, they can go for picnics, they can do sports. So I think it's definitely helping them. And with the newer kind of insulins and, using carbohydrate counting, it's definitely helping these kids.
And Cheryl, what is it?
Yeah.
Sorry.
What are the newer trends? What do you expect? What about transplants or something? See, all these children come and ask you, is there anything new? Can I get rid of this thing? Get rid of this disease? Is there anything in the horizon?
I think on a practical note, a technological solution may be feasible in the near future rather than a biological cure for this particular problem. In terms of having a closed loop where a CGM gets linked to the pump is what is going to go into the near horizon.
Dr. Latika Nair has asked, how should we shift from post-DK regular insulin to basal bolus regimen? Should we just convert total units of plain to basal bolus or calculate based on the requirements of pre-pubertal and post-pubertal groups?
Parvati, you will answer or shall I answer?
You can please, Dr. Hemchand.
See, I think there is no fixed rule of transitioning from subcutaneous, from IV insulin to subcutaneous. I think an individual decision has to be made based on the situation of the child, how sick the child was, what is the probable oral intake, and what is the age of the child, how responsive the child is going to be to eating. So different, it has to be tailor-made for the individual situation. One practice is to give a sliding dose of regular insulin every 6 hours, 6 to 8 hours, calculate the total daily requirement, and then give it as a basal shot and a bolus equally distributed. Another practice would be to start off with carbohydrate counting right away. Check, assess the probable intake of food, correct for the high sugar, and give a dose of bolus. And then slowly you shift the child obviously into the basal bolus regimen. That would be another practice. So, and I think it kind of settles down by itself. So I think one has to remember that if you're giving analogs, it has to be given about 10 to 15 minutes before stopping, and if it is regular, it has to be given about 30 minutes before stopping the infusion. And if that is followed, I think it smoothens out.
Cheryl, how good are children in carbohydrate counting? Do they learn easy, or are they, it depends on the character of this child. Some of them may be meticulous, and some of them are very careless. So what is your experience? You must be having a lot of children.
Yes, yes. So most of them learn it well, and we step it up. So basically, once they come to us, we handhold them for 2 to 3 weeks so that they get the right understanding. So we are regularly in touch with them and the parents. And then because of the peer group support also, they get a lot of help, and they see that it definitely helps them. And I think today with CGMS and all, it really gives them an idea on how carbohydrate counting, and if they accurately carb count, it really helps them to get their time in range. So it is, and we definitely have some, especially the adolescent age group. Sometimes, they misuse carbohydrate, the whole carb counting thing. So therefore, you have to be very strict in, in educating them about the principles of right eating right from the beginning.
Can I ask one question to Cheryl, sir?
Sure.
Cheryl, can you just share your take on giving sugar-free substitutes for children?
I'm not in favor of it, though it is recommended. So stevia and sucralose is recommended. However, we tell them to, and even if you look at the ISPAT guidelines, they say you can take sucrose, just count it in the total carbohydrate intake, and 10% of sucrose in the total energy is allowed. And we asked them, like today only one of my children wanted to eat gajar halwa, which is carrot halwa, and carrots are in season. And they were so happy to see that even after having that, the glucose levels were very well controlled post having that. So we allow them to take sugar, and I don't really encourage sugar freeze.
These children contact you for doubts,
Yes.
regarding your diet or your insulins. Do they, as they become adolescents and adults, do they still contact you as they become adults?
Yes, yes. In fact, some of them, like I start feeling how old I am, because somebody would have seen me 15 years ago and now is like a boy who's already working. And, then they tell me, I contacted you, or I met you for the first time when I was 10. And it really makes me feel very old.
Do the pediatric endocrinologists have this? Do the pediatric endocrinologists also have this experience that, when they become an adult also, they contact you?
They contact us.
We hope that will happen.
I think they're very comfortable.
They're kind of addicted to the system of close contact, which actually is not available in many adult services. The personalized touch that is there in as pediatricians, which we consider themselves as a part of our family. And when the cold treatment, it's a cultural shock for them.
Yeah. Kids, that's great. Pediatric endocrinologists continuing to look after them as they become adults. Okay. I think we've done the questions. The winner of the quiz can promote. Can you?
Yeah, so once again, it's Savita, Dr. Savita, who's a postgraduate.
My gosh, she's won 5 times so far.
Wow.
So from Trivandrum Medical College. So
Savita, can you show yourself again? Savita, are you here? Yeah, there she is. She's a brilliant PG student from Trivandrum. She's won it now the 5th time. Is it, Savita? Savita, unmute.
Yes, sir.
5th time she's winning our quiz. And that is amazing. This is fantastic, Savita. All the best in all that you do. What are you going to take up finally? You've been winning all the quizzes, most of the quizzes, you know. What is your super specialty you're going to take?
I'm not sure, sir.
Not sure, is it?
Not
decided.
I'm not sure.
Not sure. But whichever specialty you take, it's going to be great. Thank you so much for participating in all these quizzes. You have done a great job.
Thank you, sir.
So I invite Dr. Pramod to say the word of thanks.
All right, so we have come to the very interesting session, and to conclude, I must thank Dr. Parvati, Cheryl, and Dr. Hemchand for the wonderful presentation, and Dr. Jason for chairing the session, and all the participants for attending this important session. And thank you and good night all.
By the way, I must thank Parvati for getting these for Cheryl and Hemchand. Hemchand was a revelation. Cheryl I've heard when she came to Aster, but Hemchand was great. Thank you, Parvati, for getting the faculty.
Thank you, sir.